Hey everybody, my name is Deshaun Green, and this is my presentation called All of the Above. We're going to be addressing the health gap currently happening in the community because of AI and what we can do to earn the trust of those people. In modern public health, the trust gap is a primary driver of widening health disparities. We see this manifested in a reluctance to participate in preventative screenings, a hesitation to join clinical trials, and a delay in seeking timely care. But we must be clear. This mistrust is not a lack of information or ignorance. As my research shows, it is rational skepticism. It is a protective mechanism born from generations of systematic trauma, from the 40-year-long Tuskegee Syphilis Study to the unauthorized use of Henrietta Lacks cells. Medical institutions have historically engaged in a pattern of exploitation and dehumanization. Data from the Pew Research Center confirms this. 60% of Black Americans view misconduct by medical scientists as a major problem. This historical friction isn't just a memory, it's an institutional injury that continues to depress participation in public health today. Now we face a new frontier, artificial intelligence. AI is often marked as an objective tool, but in reality, it can act as a high-speed accelerator for the biases of the past. Consider the vicious cycle of exclusion. When a community has rational reason to mistrust the system, they are less likely to engage with data collecting health services. This results in data silence, a lack of representation in the datasets used to train AI. When developers build algorithms on this skewed data, we get algorithmic bias. A landmark 2019 study by Meyer revealed that a widely used health risk algorithm used healthcare costs as a proxy for health needs. Because the systematic barriers meant less money had historically been spent on Black patients, then the AI would incorrectly flag them as healthier than white patients with the exact same conditions. Correcting this one flaw would have increased the number of Black patients receiving critical aid from 17% to 46%. Without ethical governance, we are effectively programming the inequities of the 1930s into the automated systems of the 2030s. Our analysis must go deeper than race alone, though. We must look at the structural inequities in education and the professional biases of ageism. Disinvestment in public schools in marginalized areas leads to lower health literacy, the very tool needed to navigate complex AI-driven health info. Furthermore, we see a parallel crisis in ageism. Many providers hold outdated beliefs that older adults cannot or will not use the digital health tools. Yet, the COVID-19 pandemic proved that when given the opportunity, older adults are highly capable of using telehealth to reduce the barriers to care. So what can we possibly do to fix all of this? I call it the two-pronged strategy for reconciliation. Firstly, we have CPPR, or Community Partner Participatory Research Coalitions. We must move from consulting the community to sharing power with them. The coalition would include elders, faith leaders, hospital CIOs, and data scientists. And most importantly, the community members have the power to veto anything they do not feel is representing them correctly. Secondly, we must have ethical leadership as corrective action. Leadership in the AI era requires more than technical skills. It requires moral agency. AI in health should allow for individualized, targeted care. Ethical leadership means being willing to prioritize justice over operational efficiency. It means empowering a developer to kill a project that might be profitable but is socially irresponsible. In conclusion, achieving health equity in a digitized world is not a technical challenge, but is a leadership challenge. We cannot demand trust. We must earn it. And by acknowledging historical trauma, involving the community as co-governors of technology, and using AI specifically to close resource gaps, we can turn systematic mistrust into systematic partnership. The future of public health isn't about algorithms, it's about all of the above.